Spin Essentials, the core topics in pediatric neuroimaging essential for daily practice, packaged as our holiday gift to you.
So, quick outline. We will quickly talk about what the normal cerebellum and brainstem should look like. We'll speak about some simple definitions, and I'll show you some examples of cerebellum and brainstem malformations with known genetic causes, and some specific malformations where we think they probably have a genetic cause, but we don't know it. And I'm going to keep this quite simple because it's supposed to be a pattern recognition sort of workshop, so I'll just settle for some pretty simple patterns to recognize. So, normal cerebellum. The height of the pons, I'm sure you've seen this before, should be about twice the height of the midbrain and twice the height of the medulla. The tegmen of the pons should be flat. The cerebellar vermis should extend from about the inferior colliculus to the obex. Should be fairly symmetrical, superior and inferior vermis. The vestigial point should be in the middle. And when we look on the axial images, we should see these sort of concentric, sort of almost onion layer sort of appearance of the cerebellar foliae. On DTI, we can see the corticospinal tracts, medial lemnisci. Obviously, there's further other things that we can see, but these are the most basic ones, and then the transverse pontine fibers. Quite conveniently, the AP diameter of the pons is also about twice the AP diameter of the medulla, and I personally don't really like measuring things, but we have to remember that the mesencephalon and pons both still show substantial growth from birth throughout childhood. So if we think it's not quite right, we probably need to measure things. And that's even more true for the vermis, because you can see how there's still exponential growth of the vermis in an early childhood. So basically from birth to 10 years of age, it doubles in height, right? And so especially in preterm kids, we probably need to look at fetal charts if we want to make sure that the size is correct. All right, some simple definitions that were worth reviewing. Cerebellar dysplasia, which is what I'll be talking today, cerebellar dysplasia or malformation, is basically an abnormal shape of the cerebellum. Cerebellar hypoplasia is a small but otherwise normal cerebellum, and cerebellar atrophy is a cerebellum that was initially normal and then develops enlarged fissures due to tissue loss. And you will probably appreciate that sometimes it's a bit hard to tell the difference between hypoplasia and atrophy, and we might need a follow-up scan to confirm that something is atrophy and not just hypoplasia. So how do we approach cerebellar malformations with pattern recognition? So we look, first of all, which part of the cerebellum is abnormal, be it dysplastic or be it atrophic or atrophic. Is it the vermis or is it the hemispheres? We look for cerebellar cysts that can be very helpful. Is the brainstem normal? Is the corpus callosum normal? Are the basal ganglia normal? And are there malformations of cortical development? So here we have a patient who has a few findings. So first of all, we can see there's a cerebellar dysplasia. The foliation is not that onion layer appearance that we would expect, but that's not the only abnormality. We can also see the corpus callosum is dysplastic and probably doesn't project that well, but he's got some polymicrogyria in the perisylvian region. And the combination of these three findings is quite characteristic for Chudley-McCullough syndrome, which is caused by GPSM2 mutation. Now, this next patient didn't have any supratentorial abnormalities, which is why I'm only showing the brainstem. And most of you probably already recognize what this is. So we've got a cerebellar dysplasia with cysts, and this is Poretti-Boltzhauser syndrome, which is caused by a LAMA1 mutation. It's also interesting to see here. So when we have cerebellar dysplasias, we expect ataxias, but obviously here you also have cognitive impairments because of the cognitive involvement of cerebellum, even though there's no supratentorial involvement. Now, other cerebellar dysplasias with cysts, GPR56 mutation, so the gene has been renamed recently. Here we also see cerebellar cysts, and we have supratentorally frontoparietal polymicrogyria and quite abnormal white matter signal, and then also what we've seen earlier today as well, the alpha dystroglycanopathies, the most severe version of the Walker-Warburg syndrome, this sort of Z or S-shaped brainstem, and then other milder forms such as Fukuyama congenital muscular dystrophy and muscle eye brain disease. So moving on to the next pattern, and again this is pretty straightforward. So we see a cerebellar dysplasia. It's asymmetric, just looks wonky, right? So you've got an asymmetric pons, you've got an asymmetric cerebellum. Supratentorally, we can see the basal ganglia look very abnormal, dysplastic, and they're partially fused. You can also have malformations of cortical development to various degrees, maybe just dysgyria, so slightly abnormal gyral pattern, but that also extends to pachygyria, PMG, and we also often have an abnormal corpus callosum, and this is an example of a tubulinopathy. There's quite a few of them. They can have a fairly variable phenotype, so a lot of them will have what we're seeing here, others will have much more extensive supratentorial malformations. And then, as you remember from Christina's talk, TUB4A actually doesn't cause this phenotype at all. It causes an HABC phenotype, so hypomyelination with atrophy of the basal ganglia and cerebellum. These are autosomal dominant and mostly de novo mutations. All right, so the next case, again, something you will all recognize, hopefully, is the molar tooth. Clinically, these patients often will present with hypertonia, ataxia, oculomotor apraxia. It's a typical symptomatology. And on the molar tooth obviously consists of these thick horizontal SCP and a deep interpeduncular fossa. The vermis is hypo or dysplastic, and what's an important feature is the sort of elevated vestigial point that you can see from the hypoplastic inferior vermis. So, Joubert syndrome and related disorders. If you've got it like this, it's pretty straightforward, but sometimes it's a little bit more complicated because the molar tooth may not be as obvious. So in this case, you'd be pretty hard-pressed on the axial view to say it's a molar tooth, but this is actually also a patient with Joubert syndrome. So you can have mild molar tooth malformations, for example, an NPHP1 mutation. You can see the vermis is definitely abnormal, dysplastic inferior, hypoplastic inferior vermis, and an elevated vestigial point. So in these cases, DTI can be helpful because one of the findings that we see is that we have the absence of the decussation at the level of the SCP. So instead of having this red dot here, you won't have the red dot. And because of the AP coding, if the superior cerebellar peduncles are more horizontal, they will look more green, just because of the encoding direction definitions. Joubert syndrome and related disorders have more than 40 known genes nowadays that can cause this. There's quite a large overlap with other ciliopathies, and what's also important is that about a third of the patients with a molar tooth malformation, we can't actually find a causative gene. So in this graph here, you can see maybe 8 or so genes are the cause for about half of the Joubert syndromes. None of them is more than 10%. There's a group of other genes that weren't differentially sort of shown here. These are just the other 30 or so. And then in about a third, we don't see any, we don't find an abnormal gene at all. And here actually the MRI is quite helpful because finding the molar tooth on the MRI will help you try and find possibly a causative gene or defining new genes that may be causing Joubert syndrome. So this is a suboptimal image, obviously. Apologies for that. This is a 12-day-old term little baby girl who had uncomplicated pregnancy, but low outgoes at birth and high lactate. She's lethargic, had some breathing difficulties, and we did this MRI, and the question from the clinicians was, is this a mitochondrial disorder? And you can see, or you can't see very well, but she's got a small cerebellum. She's hypomyelinated for her age, so there's no, you can't see the internal capsule. There's no restricted diffusion, but there was a lactate peak. So this is a phenotype of pontocerebellar hypoplasia. This term is actually, I find, a bit confusing because it's technically a misnomer, because the first two types of pontocerebellar hyperplasia aren't actually hyperplasias, they're neurodegenerative disorders that have an antenatal onset, so they're progressive. Most pontocerebellar hyperplasias that we have defined, and there's currently 13 plus subtypes that have this label PCH, are neurodegenerative disorders, but some of them are also static. And then we have other causes that have a pontocerebellar hyperplasia phenotype and that don't have the label of PCH. So, and I find this a quite helpful little graph that shows the associated infratentorial and supratentorial abnormalities. And if you look at our case, we've got hypomyelination, so that narrows it down to about 10 genes or so. And if we take another approach, sort of the more clinical approach, and look at, we've got the respiratory failure, we also had the lactic acid elevation, we end up with PCH type 6, and this is what this patient had. This is caused by a mutation in the RARS2 gene. This case you've seen in a prior talk, and this is one that I actually got wrong when the patient came around. This is one of Jane Anthony's patients. And she came and asked me, what is the gene? I said, oh, I'm not really sure there's a gene at all. It looks like they've got some, white matter loss supratentorially. Looks sort of PVL-like. They've clearly got, so the vermis look normal, but then you've got sort of this loss of the inferior parts of the cerebellum, and I wasn't quite sure, couldn't really quite make a rhyme of it, but I just hadn't seen this before, right? And that's an important point. You can only diagnose the things that you know. So this is pontocerebellar hypoplasia type 9. We've got a combination of a cerebellar atrophy with sort of this dragonfly appearance, which you can see in other types as well, and then the figure of 8 brainstem. I think it's more of an infinity sign rather, because it's sort of on its side, but yeah, anyhow. Supratentorial white matter loss and very thin wraps in corpus callosum. This is actually quite a characteristic pattern that's worth remembering for the one you'll see once in a lifetime or so, I guess, depending on where you work. This next patient is a 1-year-old boy, and he has a horizontal gaze palsy and a scoliosis. And those two things actually already give you the diagnosis, because this is horizontal gaze palsy and progressive scoliosis. It's caused by mutation in the ROBO3 gene, and that's involved in axon guidance. And the salient finding here is that we spoke about the pontine tegmentum, which should be flat, and here it looks like it's concave, and that's because of this midline cleft and the absence of the facial colliculi due to commissular axons that haven't really found their home. Not quite that simple, unfortunately. So there's another phenotype, or another gene actually, that causes a different phenotype of horizontal gaze palsy and progressive scoliosis. This is a gene DCC, deleted in colorectal carcinoma. It was originally thought to be a tumor suppressor gene, but it's also involved in axon guidance. And here you'll have a very similar phenotype of the brainstem, but you'll also have an agenesis of the corpus callosum as well. So if you have this ROBO3 phenotype plus agenesis of the corpus callosum, then it's horizontal gaze palsy and progressive scoliosis type 2. Moving on to a sort of the opposite pattern of the brainstem abnormality. So here, instead of having a concave pons, we have this weird-looking cap, and it's actually formed from transversely organized fibers. So these are fibers that have formed in a wrong position. This patient presented with left-sided sensorineural hearing loss, and you can also see there's mild atrophy of the vermis as well. So, as you all probably know, this is pontine tegmental cap dysplasia, and this is one of the conditions where we presume that there's a gene causing it, or possibly even multiple genes causing it, and it's probably due to abnormal axonal guidance, but we haven't really found the gene yet. Patients typically present with hypotonia, pyramidal and cerebellar signs, and multiple deficits of the cranial nerve, such as in this patient as well. And they can also have other malformations, cardiac, gastrointestinal, genitourinary, and skeletal, especially the ribs can be abnormal in these cases. So, the famous Dandy Walker malformation. We get quite a few patients sent to us with a preliminary diagnosis of Dandy Walker spectrum, Dandy Walker variant, Dandy Walker complex, and as we heard also from the discussions with Stacy Gergen yesterday, those terms are not very helpful, and they cause more confusion than they solve. And these are pretty simple findings that obviously only one of these is a Dandy Walker malformation. So this first one's just an arachnoid cyst. You can see there's a posterior fossa cyst. The posterior fossa is probably a little bit enlarged, but that's just because it's the scalloping from the cyst. The vermis is actually normal. It's just being compressed. It's not communicating with the fourth ventricle. So it's just an arachnoid cyst. The second one is a Blake's pouch cyst. So we do have a cyst that communicates with the fourth ventricle, but the posterior fossa is not enlarged, and the vermis is actually normal. These kids virtually always have hydrocephalus, because it's basically an obstructive hydrocephalus caused at the outflow of the fourth ventricle due to failure of regression of Blake's pouch and perforation of the foramen of Megendi. And this patient is the Dandy Walker malformation with the hypoplastic vermis, cyst communicating with the fourth ventricle, and enlarged posterior fossa. So now, once we establish that it's a Dandy Walker malformation, we're actually not at the end yet, because it's not really a diagnosis, right? It's a phenotype. And while the Dandy Walker malformation is a feature of multiple genetic conditions with other congenital abnormalities, in the majority of cases we don't find a genetic cause. And there's actually also a growing body of evidence that suggests that the Dandy Walker malformation can be caused by extrinsic factors. So we have this recent study by Haldipour and colleagues where they could show that an insult to the rhombic lip before the 14th week was the inciting factor to cause the Dandy Walker malformation. And this could be due to vascular insult, it could be due to issues with intrinsic cellular programming, so it could be due to genetic or acquired causes. So it's probably more of a phenotype than a diagnosis, and also the clinical presentation is quite variable. The last malformation I would like to show you today is rhomboencephalosynapsis. You've all seen this before as well. It's characterized by fusion of the cerebellar hemispheres with partial or complete absence of the cerebellar vermis. It can also be part of a syndrome, such as Gomez-Lopez-Hernandez syndrome, where there's also dysmorphic facial features and this parietal alopecia and trigeminal anesthesia. So despite quite extensive research, no genetic cause has been found for this yet. And with that, I'd like to show you a case that was recently showed to me. So here we have a fetal ultrasound with rhomboencephalosynapsis. We have pathology confirming that it's rhomboencephalosynapsis. And surprisingly, the genetic testing revealed maternal and paternal variants of unknown significance in the LAMA1 gene, which, as you know, causes Barrett-Boltzhauser syndrome. So is there a causal connection? We don't know, but probably not. So the issue is not that the phenotype isn't quite, or isn't at all really, LAMA1. We don't see any cysts, but the cysts don't have to necessarily be formed at this point. We know from the dystroglycanopathies that they often form later. But the main issue is that no association between LAMA1 genes and rhomboencephalosynapsis has been reported so far, despite extensive research. So it's probably just a genetic incidentalloma. And when I showed this to Moig and Boltzhauser, he showed me these two papers and said, LAMA1 variants have been found in a range of other conditions where the causality is very unlikely. And as, for example, these examples of Joubert syndrome, and also patient with congenital contractures and no cerebellar abnormality at all. So I guess the final point that I want to make here is that unlike Drake, the Canadian hip-hop artist, we shouldn't neglect the clinical history and neurological exam in favor of the donut of truth. So MRI is not a truth machine, and I'm sure we've all especially had discussions with ED about this. But then on the other hand, and that's where we as radiologists have to look at in our own backyard, we also can't neglect pattern recognition of findings on MRI just in favor of next generation sequencing. So just as MRI, genetic testing is not a truth machine. And with that, I would like to thank you very much for your attention.